Good evening, everyone. I'm Dr. Umar Farooq. To start the proceedings, I will request Professor Talat Naheed, Professor of Medicine and Principal, Reber Medical College, Lahore, Professor Alam Zeeb Manan, ex-professor and head department, Gastroenterology, Ayub Medical College, Abbottabad, Professor Abdul Qadir Khan, Professor of Medicine, Muhammad Medical College, Mirpur Khas, and Dr. Usama Bhatt, Consultant, Transplant Hepatologist, Pakistan Kidney Liver Institute, Lahore. Our first talk will be about COVID vaccination in chronic liver disease and post-transplant patients. Talk will be delivered by Professor Adeel Bhatt, Professor of Medicine and Professor of Healthcare Policy and Research, Weill Cornell Medicine, Qatar, Vice Chair, Department of Medicine, Director, Clinical Epidemiology Research Unit, Hamad Medical Corporation, Doha, Qatar. Professor Bhatt is a Fulbright scholar, a Yale Johnson & Johnson scholar in international medicine, and has multiple other national and international awards. Over the past 20 years, Professor Bhatt has held numerous senior academic positions including Clinical Director, Residency Program Director, Division Chief, and Professor Bhatt has published over more than 250 papers in high-impact medical journals and has presented over 180 abstracts at major international conferences. Professor Adeel.
Thank you. Assalamu alaikum once again. पहली बात तो ये लगता है बट छा गए इस सेशन में. I see multiple, but Professor Arshad we have stepped out, but once again it is an honor and a pleasure to be here. I'm very grateful to PSH for inviting me yet once again for this lovely meeting in a beautiful city. These are my disclosures for the current talk, and what I'm going to do for the next 20 minutes or so is try a different format, a question and answer format, and I'm going to try to answer 4 questions related to the topic assigned to me. And these questions are, first of all, COVID pandemic seems to be over, so why bother about this now? There is a prevailing thought in some people's mind. Then we'll talk about the different variants, alpha, beta, delta, omicron. How do they matter and why do they matter? But I'll spend more time talking about patients with liver disease and impact of COVID and COVID vaccination on liver disease, and finish it off with some data that I'll share regarding the 3rd and 4th dose, and right hot off the press, actually just published in New England Journal of Medicine yesterday, or on Wednesday actually, about Omicron specific bivalent vaccine and how effective is that. So first question is, I also get asked frequently, and maybe you do too, that COVID pandemic seems to be over. So what's a big deal now? And those of you who are from the US would know this famous baseball player who said that the game ain't over till it's over. And for COVID, it ain't over. Let me show you the evolution of different variants of COVID and sublineages of COVID, SARS-CoV-2 virus. And this is only over the last 4 or 5 months or so. So you can see that the variants and lineages can change very rapidly over a period of time. And we have seen the waves over the last 2 years, the wild type virus or the Wuhan strain, then the alpha, beta, delta, omicron, and so on and so forth. And each subsequent wave can be different from the previous one. And the reasons they matter is because there are differences in the presentation as well as severity of illness related to those. We have very highly effective vaccines which are effective against infection as well as severe critical or fatal disease. However, vaccine effectiveness differs by the variant that is in circulation at that particular point in time. So on your left, you can see that as the subsequent variants came in from alpha to beta to delta to omicron, vaccine effectiveness against infection kind of decreased over a period of time. We have also shown very elegantly, the slide you can see on your right hand side, that vaccine effectiveness, even in the same variant, drops over a period of time quite sharply. So for example, for the mRNA vaccines, the vaccine effectiveness against infection, which is about 80 to 90%, in the first 2 or 3 months or so drops down to about 20 to 25% by month 6. So that is a very sharp drop. In other words, to prevent infection, it's only about 25% effective after about 6 months or so. However, the good news is that they retain their effectiveness against the most severe manifestations of disease, which is severe hospitalizations, ICU admissions, and death. And that effectiveness against those outcomes is still about 70 to 75% or so after about 6 months of vaccination. The other important thing to remember is that even though these are highly effective vaccines, there are breakthrough infections that occur after full vaccination. So again, we showed in this major study that both people who have been infected naturally as well as those who have not been naturally infected, but both groups who have been vaccinated do develop subsequent infections, what we call breakthrough infections, over a period of time. And why are these important? Because breakthrough infections do carry some amount of morbidity and mortality with them. The key message here is that if you are vaccinated and develop an infection, as compared to unvaccinated and develop a first or a second infection, then your chance of ending up in a hospital or in the ICU or dying are much lower. So vaccination really protects you, even in breakthrough infections. But remember that breakthrough infections do occur. That is why this epidemic or pandemic is not quite over yet. And again, some outcomes that we have published over a period of time, both from this part of the world and in North America, that the outcomes are similar, meaning breakthrough infections occur, but vaccination leads to lesser severity of disease. What about all these different variants? Why are they important? I'll give you a hypothetical example that when we compared alpha with delta, for example, the R naught was significantly different. So in mathematical modeling, if you have a virus or a variant which has an R naught of 2.5, means each infection leads to 2.5 infections, and those 2.5 infections, each one of them leads to 2.5 more. After about 10 cycles of transmission, in the susceptible or a vulnerable population, it will end up in about 10,000 cases. However, if the same virus mutates and the R naught is now 6, the same 10 cycles of transmission will lead to 60 million infections. So that is the big difference between subsequent lineages and subsequent variants of concern. And that is why we are still very concerned that the virus might evolve or mutate at some point into a much more transmissible virus. Another thing to note is that disease severity varies, and we have shown in a series of papers, and now we have come full cycle, we've compared all the variants over a period of time, and we've published several papers in a series that Delta was far more severe than the Beta infection. However, Omicron was less severe than Delta. Omicron is more transmissible, but less severe in terms of its outcomes or leading to critical disease, hospitalizations, ICU admissions, and death. So that is why these variants do matter. And again, similarly showing these data in people who have received a booster dose compared with those who did not receive a booster dose, that Omicron related hospitalizations were negligible compared to Delta. Again, in a series of several papers, we have shown vaccine effectiveness against all the different variants. And as I mentioned earlier, the vaccine effectiveness for subsequent variants decreases over a period of time, however, for infection. However, for severe or critical or fatal disease, the vaccine effectiveness still remains very, very high. So infections will continue to occur despite vaccinations, although at a lower rate, but the severity of infections and the consequences will be much less severe, and this is a pattern we hope will continue. Moving on to the more pertinent topic that was assigned to me, what about my patients who have liver disease or various types of liver disease? And this review paper summarizes this quite well. So this describes or reports on the effects of COVID-19 infection in patients with chronic liver disease, hepatocellular carcinoma, and recipients of liver transplant. And you can see that patients who have chronic liver disease, the non-cirrhotics, still have a higher mortality to the order of about 1.8 times higher mortality related to COVID. Even cirrhotics have a higher mortality, which is slightly higher than non-cirrhotics with the same diseases. Patients with hepatocellular carcinoma, if they develop COVID-19, they have 20 to 40% higher mortality. And those who are the recipients of liver transplant, again, have 8 to 24% higher mortality compared to those who do not develop that infection. And these consequences or this mortality is preceded by several different complications like pneumonia, and also associated with higher ICU admissions and hospitalization. What about survival in patients with cirrhosis? And this study nicely summarizes the effect of cirrhosis in patients with COVID. So if you have no cirrhosis and do not have COVID, you have a baseline mortality, 30-day mortality in a population. If you develop COVID without cirrhosis, obviously your survival decreases, but you have cirrhosis and then develop COVID on top of that. You can see the bottom graph line that the survival is dramatically lower than the other groups. So survival is significantly affected by COVID in patients with cirrhosis. And this survival is mostly driven, or mortality is mostly driven by patients who are unvaccinated. So this is another large study from the US which compared outcomes at 30 days in patients who are vaccinated and unvaccinated among cirrhotics. So on your left-hand side, you can see that 49% of people who were unvaccinated died or had severe complications, while among the vaccinated, this rate was only 30% or so. So those who were vaccinated had significant protection among the cirrhotic population. Now that we have established that cirrhosis is associated with more severe outcomes, do the vaccines have affected this population? And this study looks at the vaccine effectiveness against infection, hospitalization, and death. The vaccine effectiveness against any infection was about 65% or so, but it was almost fully protective against hospitalizations for COVID or COVID-related death. So in other words, while they may still get infected, but if they've been fully vaccinated, their mortality is going to be much, much lower or negligible. And this is strong data to indicate that we should push for vaccination in patients who have cirrhosis from whatever cause. Let's shift gear to autoimmune hepatitis, and I could find one study where they looked at outcomes in this population. And again, as you can see on your right-hand side in the bar charts, that people who were vaccinated, autoimmune hepatitis patients who were vaccinated, had significantly lower hospitalization rates, need for oxygen therapy, ICU admissions, and death. If you got full vaccination, meaning 2 doses, or if you got a 3rd dose, your protection is even better. But any amount of vaccination helps you. For full benefit from vaccination, you need to give a full course, including the booster doses. Talking about liver and kidney transplant patients, data are clear now that they have a higher incidence of COVID-19 infection. And for some reason that I've not been able to figure out, the incidence of infection is higher in kidney transplant patients compared to liver transplant patients. So liver transplant patients have a higher than baseline rate, but kidney transplant patients, as you can see from this large study, is even higher. And as the variants have progressed from alpha to beta to delta to omicron, the incidence has risen among these populations. And the outcomes, which are hospitalizations, ICU admission, and mortality, are of course more in this population compared to the general population. And again, for vaccination seem to be very, very strongly protective for these outcomes, for these critical outcomes. Talking about moving forward with solid organ transplant patients, these are highly immunosuppressed patients because of the drugs we give them to suppress their immune system. The first question obviously is, are the vaccines immunogenic? In other words, do they lead to antibody response in them? Because that is a precursor to development of immunity against infection or consequences. So this study showed that if you give them only 1 dose, about 4% of the people with solid organ transplants develop antibodies. If you give them 2 doses, 40% develop that. But with a 3rd dose, 2/3 of the patient would have detectable or significant amount of antibodies against the virus. And that does translate into vaccine effectiveness as well. So those who have received the vaccine not only develop antibodies, but also clinically protected against symptomatic infection, as is clearly demonstrated in this study. This is another way of showing immune responses to third and fourth doses in people who are liver transplant recipients, and fourth dose gives you a little bit further boost in your immune response as measured by the antibody levels. We have submitted a paper on vaccine effectiveness in patients with inflammatory bowel disease. Mind you, these are data for the earlier variants, not Delta and Omicron. So two of my fellows wrote that. So vaccine effectiveness was in the range of 80 to 90% or so, with the caveat that these are the earlier variants and not the more recent variants or the sublineages of Omicron. But my suspicion is that even with the newer variants, infection rates may be higher, but the protection against severe disease, which is actually what we want to prevent or stop, is going to be very, very high. So let me finish off by discussing the need for a third or a fourth dose, or what we call the bivalent vaccine, which is commonly known as Omicron specific vaccine, which has just been approved or received authorization in the US. I think for the third dose, the data are very, very clear. We have published about 15 papers on various aspects of immunity of second and third doses, that it is highly protective against infection. And the reason for the third dose, I also mentioned earlier, is that with two doses, your immunity or your effectiveness of the vaccine drops very significantly, so that by the end of 6 months, whether you take the Pfizer vaccine or the Moderna vaccine, infection prevention effectiveness is only about 20-25% or so, but against severe critical or fatal disease, we're still looking at 60 to 70%. And this has been shown both in the pre-Omicron era as well as in the Omicron era. So in other words, whether you look at the older variants, newer variants, and even the BA1, BA2 variants, and the more recent variants that have come out, sublineages that have come out, 3 doses have been shown to be more effective than 2 doses. Now, what about the fourth dose? And I have seen a lot of hesitancy in people for taking the fourth dose for various reasons. People just do not want to go for the fourth dose. There is no question that getting a fourth dose is more effective when you compare with 3 doses alone. So here you can see that the comparison is not between 4 doses and 0 doses. It's between 4 doses and 3 doses. So protection against any confirmed infection is 52%, 4 versus 3 doses. And for severe disease, it's about 70 to 75% or so. So 4 doses are clearly more effective than 3 doses. The hesitancy that I see is that because the severity of illness is so low in Omicron era, that the absolute difference between the third dose and fourth dose outcomes has become very small. The relative difference is very, very large, as you can see, about 70-75% or so. But when your baseline rate of hospitalization or ICU admissions or deaths is extremely low, then the absolute difference becomes very low in the 2 groups. Again, another study showing that with the fourth dose, you really decrease the risk of any severe complications of COVID-19 infection. And finally, the final slide about bivalent mRNA booster vaccine. Is it immunogenic? And this study was published just last week in the New England Journal of Medicine. Again, clearly shows that fourth dose gives you a better antibody or immune response. And there are early data showing that this does translate into effectiveness against Omicron-specific subvariants and so forth. What you can see with the comparisons that I made is that the neutralizing antibody titer against the ancestral or the Wuhan strain, although those titers go up as well, meaning for the earlier variants, the fourth dose is immunogenic, but that immunogenicity with Omicron-specific vaccine is much higher, meaning you develop much higher comparative antibody levels against the Omicron sublineages with this bivalent vaccine, what we call Omicron-specific vaccine. One interesting thing that came out of this study, and I was trying to analyze this in this short time that I had to read this, that the 2 groups, the 4 the bivalent group and the non-bivalent group, the 3-dose group, the number of people with breakthrough infection was not much different. However, these are only preliminary data, and we need to wait for the final analysis to see if there was any significant difference. Remember, this is very early on. In the early days after giving vaccine doses, in the first 7 to 14 days or so, you do not expect to see a large difference in clinical outcomes. The difference in clinical outcomes becomes apparent only after 14 days, up to 3 or 4 or 5 months or so, because that is the time that is required for the body to develop antibodies and to develop that immune evasion. So to conclude, the pandemic is not quite over. Vaccination of all persons is vital. We also have a very, very large global population that has been naturally infected, so that is very helpful. And by the way, I didn't show those data. We have shown in a couple of studies that natural infection gives you far higher antibody levels and level of clinical protection than vaccination would. Not that you should try to go out and get infected, but if God forbid you do get infected, particularly if you get vaccination on top of that, that is the strongest protection that you can ever get against future infection and severe outcomes. Variants do behave differently, and our fear as infectious disease doctors and epidemiologists always is that a newer variant will come that might be more infectious or more immune invasive, as we have seen in the past. Vaccines do work in special populations, and today's special population we talked about were different types of liver diseases. So in all types of liver diseases that have been studied, vaccines work quite well, and they decrease severe disease and reduce mortality, so we should push for vaccination in those people. And finally, I think a booster dose, a 4th dose or Omicron specific dose, whenever it becomes available, is a very good thing, particularly for our high risk patients like liver disease patients. I'll stop here and thank you for your attention.
Thank you. Thank you, Professor Adeel. But